Hello, Elizabeth. Hello to all of our listeners. It's 2026. It's the first episode of Health Law Simplified for season 2, and we're really delighted to be here with you. How are you doing, Elizabeth?
Yeah. Hey, Sandy. I'm doing well. Head's kind of spinning from all that's going on, but it's an interesting time for sure.
Yeah, absolutely. Just a reminder, we like to start our episodes off the same way that we start off our team meetings, with a positive focus. Do you have anything that you've come with, Elizabeth, or do you want me to start?
It's kind of a general thing. Just my job is never dull. So there's just so much. Um, I don't think I need to do crosswords to keep my mind stimulated. Like there's so much going on right now and coming out, and it's just such a dynamic time. It is a very stimulating job.
Yeah, agree. It is never boring. And my positive focus is would have struggled if we were recording this last week, but this week I had the privilege to travel to sunny Phoenix, Arizona, and go to the HCCA Managed Care Compliance Conference. And we've been going to that conference
I
for a
love that meeting.
very long time. There were some really familiar faces, good friends, clients, and also met some new folks. And it was really fun to be at a compliance conference the same day that OIG issued long-awaited, updated compliance guidance. Everyone was
Super cool.
geeking out in the middle of sessions.
Yay.
Yeah, it was fun.
Yeah, that is fun. Well, we can tell our listeners we were going to record this last week and we had, our content prepared. And then Monday night, the advance notice came out. And what was the other thing?
The
And we're
rad
like, well, we
the
can't do it.
RADV memo.
Oh, yeah, in the RADV memo. We're like, well, we shouldn't record something and not talk about that. So let's take a little more time and digest that and then be ready. And then now we have the OIG MA specific compliance program guidance, and Congress just passed an overhaul of the PBM industry, basically, PBM pricing. So we're realizing we just got to go today with what we have, right? We'll talk about those things next time, but it is really like rapid fire, major developments in the MA
Yeah,
compliance world and Part D. Sorry.
a huge shift from a year ago when CMS was transitioning and so
Yeah.
quiet for so long. So yeah, they have really figured out their priorities and are
Hmm.
putting out guidance left and right. Congress
Yep.
too.
Yep.
Yeah, that was a shock to see
Yeah.
that.
Yeah. Yeah. Lots going on. Very interesting.
With so much going on, we did a little bit of dividing and conquering. And I know you dug into the rate announcement. Do you want to just give us
Hmm.
the high level? I know it's a really lengthy document.
Yeah, absolutely. So CMS, on its routine annual schedule, released the advance notice on MA and Part D payment rates last Monday, January 26th. Late in the day, and it was a shock to the markets by Tuesday morning after health insurer stocks were tumbling in response. Overall, the impact of the rate notice would be, which again isn't finalized, this is just a proposal, would be a net increase estimated just under 1% for 2027 plan year. And by comparison, the rate of medical inflation is about 5%. So it's, effectively a cut. And so another point of comparison, the rate increase for 2026 net estimate was about 5%. So it was really a shock to the markets, to people working in the plans, and to all of the rest of us. So industry groups have been quite critical of the announcement. Typically, the final rate announcement's at least a little higher than the advance notice, but there's no way to know how or whether CMS will respond to the stock market reaction or the industry response. So this really does inject more uncertainty into the MA market. One of the most things, so of course, we're health lawyers, and risk adjustment is a very important topic, not just for the financial impact, but for the legal risk that it creates in the current environment. We are often advising MA organizations and their vendors and providers taking risk on how to design risk adjustment programs that are effective enough to keep the plans in business in terms of, identifying and properly coding medical conditions, but not incurring excessive legal risk. It's a much tougher balance than a lot of people realize to do that, even for teams acting in complete good faith. Because if you're undercoding your medical risk, you're not going to have enough premium revenue to cover medical cost. And of course, on the other hand, if you're found to overcode, the legal risk can be financially catastrophic. And that risk comes not just from audits by CMS or OIG, but from False Claims Act whistleblower lawsuits. So very interesting topic for everyone, especially geeky health lawyers like us. And we think we discussed Kaiser just settled a risk adjustment lawsuit with the Department of Justice for $556 million. I think that's a record. I think that's the highest settlement that we've seen. So, needless to say, we have been waiting for years on clear guidance from the government on the do's and don'ts of risk adjustment programs and for, retrospective chart reviews, among other topics. We were expecting guidance, but what the advance notice does is really a wholesale elimination of risk adjustment coding from retrospective chart reviews. So, starting in 2027, based on the proposal, CMS would no longer count diagnoses from unlinked chart reviews. Those are records that are added by plans that aren't coded in an actual patient encounter. They would not count those diagnoses toward risk scores. So, that would be a big change. Financial analysts are saying that this likely accounts for an average cut of about 1.5% in that rate notices, net impact. The thing is that it varies from plan to plan. Some plans are quite aggressive about those unlinked chart reviews. Some plans are not, either because they haven't figured out how to put the processes in place and or they're concerned about legal risk associated with those post-service chart reviews and submissions for risk adjustment based on those. So I'm I'm going to go out on a limb. I don't like the overall, I'll call it an austerity theme in the advance notice overall. I don't think a 1% increase is reasonable when medical cost is going up 5%. However, just looking at this unlinked chart review change, saying those are not going to be accepted anymore, I don't hate that. I've always felt like a lot of our smaller plan clients in particular are at a disadvantage because they were not comfortable keeping up with some of their competitors in terms of the retro chart review practices. And we have been this is a ridiculous way to practice law and advise clients. Rather than having regulations or guidance about that, we've been having to, filter through DOJ filings and court opinions on risk adjustment cases in federal court to try to advise plans on how to develop compliant processes, which is just not a good way to live. So we see this come up a lot in vendor contracts. It's an issue in provider contracts, especially when providers are taking risk. There's a whole cottage industry of companies that do this retro chart review work, and there's nothing wrong with that, other than the bind that this whole situation puts plans in. So it's going to be interesting to see if this is finalized, and there's also this new guidance out from OIG about MA plans that covers risk adjustment. But I will say, if I had my druthers, I'd see this change finalized, and I hope nobody's offended if retro chart reviews are really important to them. But this would certainly simplify things for plans. If, and I say that with a caveat, I want to see CMS adjust the final rates to give a reasonable, like, cost of living rate increase in light of the trends in medical costs. So that was a lot more. That was long-winded. Yeah, I think you asked for high level, but Yeah, those are my thoughts right now on the advance notice. And CMS is going to be accepting comments through the 25th of this month of February. So we shall see, but a lot of suspense on what that final rate announcement will contain.
Yeah, thank you for that, Elizabeth. And don't worry, we know you didn't make the rule. You didn't propose it, so you're allowed to have your opinions. And I think for me, the most troubling part is the combination of the effective pay cut with the massive change to risk adjustment coding policies
Yeah.
that are allowed. Yeah, I'd rather see the risk adjustment change with, like you said, a more realistic payment rate. And
Yeah.
I have been under the impression for some time that the industry is moving in the direction of prospective chart reviews. Those are more effective for actually
Hmm.
addressing patient care, getting the
Yeah,
information back
absolutely.
to providers. I do have some qualms because, or I guess some nervousness about the Kaiser settlement, because those allegations in those cases involved queries and correspondence between plan and provider. That was an integrated system, so it was a little different than what independent, unaffiliated plans are dealing with, but it does introduce a bit more risk into those proactive measures,
Hmm.
risk adjustment measures that, we've got an asterisk. We know that the OIG guidance is out there, and there's going to be more coming from CMS. But yeah, those are my thoughts on that.
Yeah. So interesting. What else is new, Sandy?
Well, we got on Tuesday of last week, the January 27th, a memo from CMS updating plans on the status of contract specific RADV audits. Just as a reminder, last May, about 9 months ago, CMS announced a RADV audit blitz, a proposal to audit every single contract at every single plan, and to do so in short order and to extrapolate errors across the entire contract and collect contract level recoveries. That plan was delayed very quickly because a district court invalidated CMS's extrapolation rule and another element of their methodology, the audit methodology, specifically the fee-for-service adjuster. So that undermines the methodology that CMS was planning to use for the RADV audits. So we had heard, RADV audits are still continuing on for payment year 2019, but we had some questions about what CMS's plan going forward. And this memo is just an update on CMS's plan. So in the memo, notably, CMS says strengthening oversight of MA payments is a top priority for this administration. So that is, a reiteration of a commitment that they articulated last year, and we can expect these audits are not going away. CMS noted a federal estimate that has been floating around for a very long time, suggesting that Medicare Advantage organizations have received $17 billion in overpayments. That's based on a particular estimate, but that is what is driving this effort by this administration. And then CMS did confirm that it's going to begin recovering overpayments for payment years 2011 to 2013. That might be surprising to folks who are not deep in this world, that those years over a decade ago have still not been collected, but that's the reality.
Which wouldn't and those wouldn't be extrapolated,
No,
right? They said they were going to start extrapolation in 2014, but they still
yeah,
want to just collect what they identified from the
yeah.
samples.
It's
Yeah,
2018, I
that is
think, is
interesting.
when they're going to start
Oh, sorry. I'm
extrapolating.
sorry. You're right. You're right. You're right.
But there's these findings of plans that were audited for those payment years and years ago. And so those recoveries are going to begin soon. And then CMS also confirmed that it is going to initiate a RADV audits for payment year 2020 this month, February of 2026. So things are moving forward.
Although, that's such a huge improvement over trying to do 5 years at a time.
Oh,
Like,
absolutely.
kudos to whoever convinced in leadership, like, 5 years is too much to do at one time
It
for anyone.
it really
The auditors, the auditees, everybody.
it really was overambitious, and I think we had questions about how realistic it was. And this is one piece of the memo that I found helpful, reassuring to me as somebody in the industry, which is CMS said that it has been talking to stakeholders about its audit strategy and that it has refined its approach to be attentive to the operational reality for plans and providers. So they have the CMS has made some changes to the audit strategy. Those include more time to submit medical records. In the announcement last year, there was going to be a very, very short window of time to submit medical records. And CMS has said we're going to go back to the 5-month window to submit medical records and extended the time available to request a hardship exception with that timeline. And CMS has said it's going to initiate RADV audits every 3 months and is going to publish a calendar describing the cadence of the audit initiations so that we can plan in advance. CMS,
Yay, planning.
yay, yeah, planning.
Yay, plan in advance.
I love a calendar. And CMS, it touched on the sampling methodology, said that it's going to use the sample size could vary. It could be 35 enrollees, it could be 200, but that is going to be based on the contract size or similar criteria. And CMS said if it's a smaller contract, it's not going to be 200 enrollees. It's going to be smaller for the smaller contracts, which makes sense. CMS addressed the medical record requirement. One medical record is required to support a payment. And CMS has said that for these audits going forward, a maximum of 2 medical records per audited HCC is going to be allowed. I think their previously plans were submitting as many as they could to try to get support for that that HCC. And, CMS wants to strike a balance between keeping the burden manageable and moving the audits forward at pace. And then good news, CMS is not using AI just yet. CMS confirmed all medical record coding decisions that could result in an overpayment determination will be made by a human certified medical coder. So that's what we tell our clients to do. Of course, we want the government doing that as well. They're very much still looking into technology that's powered by AI, but they committed to it being fully tested before it's implemented in RADV audits, which is wonderful just because the stakes are so high and we want them to get it right.
Yeah.
Oh, and CMS committed to it will comply with the district court's order, striking down that extrapolation rule. So as long as it remains in effect, it will not be extrapolating payments.
Yeah. Yeah.
And that's the update.
I feel like that's a really great development, 1 year at a time. A lot of suspense around what ends up happening with the extrapolation rule, but yeah, it seems like a good approach.
It's great to get just some timely information and updates. Often CMS is behind the curve on what the industry is doing. At least there's a reflection of how quickly things are changing and an effort to meet the plans where they're at.
Mm-hmm. Yeah.
So besides these big topics,
you want to talk big picture?
Yeah, I know we wanted to get into some big picture MA trends for this year. Would talk about enrollment. I know you put together some thoughts on that, Elizabeth.
Yeah, we don't have the enrollment numbers for 26 as of the recording of this episode. However, just looking back, I think it's interesting that enrollment growth into MA flattened a little bit last year. So going into 2025, we'd been seeing like 2-3% increases in the percentage of Medicare beneficiaries in Medicare Advantage. That in 2007, it was down at 19%. By 2025, it was up to 54%. However, the trend did flatten a bit from 24 to 25. It was not the rate of 2-3% growth we had been seeing. And that was a really interesting development because, that tells you a lot of things. That tells you that more people aging into Medicare might be thinking about, is Medicare Advantage the right choice for me? Do I want to think about MedSup? It might tell you that some people were, opting out and going back to original Medicare, depending on what other coverage options they had. So just an interesting development. I think a big story right now within Medicare Advantage enrollment is the growth of special needs plans. Um, that did flatten a little bit going into 25, but it seems to be a strategic focus area for many plans. And within SNPs, the growth story was in chronic C-SNPs, so chronic or disabling conditions, special needs plans. And that tells us something about MA organizations thinking within these targeted populations of people with certain chronic conditions, we can do a good job of reaching people and managing care. I I will be it's harder to find med sup enrollment data. It doesn't come out as, in as standardized a way, but I will be watching any information I can gather on med sup growth or lack just trends, because with the some of the negative press about Medicare Advantage and just I think a broader understanding of the distinction between original Medicare and Medicare Advantage in terms of networks, as some providers are leaving MA networks, and there's just more awareness of the managed care features in Medicare Advantage. I'm wondering if we'll see more people who have the financial means to pay a MedSup premium on top of their Part B premium, on top of a standalone Part D premium. They can also pay for MedSup, which for those who aren't familiar, costs generally considerably more than Medicare Advantage. If people who can bear those costs will be looking at going that route, we shall see. But it's a very dynamic time in the senior market.
Have you thought, Elizabeth, do you think that if CMS finalizes the proposal to create a new special enrollment period for folks who experience a network change, a provider network change mid-year, do you think that could lead to an increase in MedSup enrollments?
It could. Providers are, as they see a growth in their patient population, especially for inpatient hospitals, as more and more of the patients on their wards are enrolled in Medicare Advantage plans, they are developing strong opinions about what plans they don't mind working with, really mind working with, would rather, it, and they're willing to take action based on those preferences. So it's not, and it's not just the rates. The rates matter a lot, but also the working relationship between the provider and the plan matters. And so I do think potentially there could be an interest on the part of patients and potentially their providers in creating conditions where people can return to original Medicare and buy MedSup. And what I'm getting, the connection I'm making there is that when somebody gets a special enrollment period, so under current rules, if there is a significant network change that's deemed, quote, significant by CMS, like a large system leaving a MA carrier's network, then the notice that CMS mandates go to those affected members that are patients of that provider that's leaving. That notice not only tells them you've got a special enrollment period to change to a new MA plan that is in network for your provider, they also get a notice that they have a guaranteed issue right to a MedSup plan without medical underwriting if they return to original Medicare. That's significant. And so I don't know. There's so many things I could say about this because brokers have generally less of an incentive to sell MedSup because you do not receive renewal commissions indefinitely. I think it's a 6-year cycle of renewal conditions. Commissions. Where in MA, those renewals you can receive indefinitely. So there are other factors at play there in terms of what gets sold to people. However, I think there is a market of patients that are affected by some of these things to move into MedSup, and it could drive growth there.
Yeah, those are really great points.
What a system. My gosh.
Yeah, and
You can't make this stuff up.
and when you think
It's just
about
so
renewal commissions, they
I
continue
know.
indefinitely for now, but I would be not shocked at all
Exactly.
if
Yeah.
we see changes
Me
in
neither.
those
Me
in
neither.
those.
Yeah. But so often we talk about this and you're like, it really is our healthcare financing system really is like a hodgepodge city that never had a planning commission.
None of us
Like it
wanted this.
really is such just yeah, it's such nobody did, no Congress, nobody. Everybody's just doing the best they can, but it really is a Frankenstein situation.
Yeah, I think a lot about how health law is taught in law schools, and how healthcare is taught in undergrad. And I've often heard folks lament that the focus is on the provider side, and that there's very little attention given
Mhm.
to managed care and payer functions. But I get it; it's very complicated. I wouldn't want to teach the history.
I know, I know. So interesting. But yeah, good question. I think we will hear more about MedStop in the coming years.
Agree. Thanks for the update. Big picture enrollment trends. It'll be
Absolutely.
very interesting to see the numbers for 2026.
For sure.
I am glad you talked about D-SNPs and how there's been, relatively more expansion in SNP enrollment, because I wanted to spend a little bit of time talking about special needs plans. They are very important to many of our clients, and as you alluded to, a critical investment for a lot of plans. A lot of folks are considering
Mhm.
going into this area, but CMS has been regulating and really putting its fingers on the levers in special needs plans for the last several years. So there's a lot of evolution in that system, and if it's an area where you're thinking of expanding, you need to pay attention to what's happening because it's changing rapidly.
Mhm.
So D-SNPs, the goal really of a D-SNP for dual eligible members, members who are eligible for Medicare and Medicaid, is to help members coordinate care between those two systems. But, the programs are ultimately quite separate, right? With separate benefits, separate administrative processes, separate claims processes, separate appeals and grievances. And that fragmentation can lead to gaps in care and, situations such as like avoidable hospitalizations, just bad member experiences. So a big part of CMS's effort over the last maybe 8 years or so is to improve integration between the two systems and to
Mhm.
require D-SNPs to do more and more integration between Medicare and Medicaid. And, when I talk about integration, what I mean is maximizing the coordination of care across services so that somebody at the plan is looking at what the member is getting from Medicare and Medicaid, and coordinating,
Mhm.
ensuring that costs aren't being shifted from one program to another unnecessarily, and then just creating a really seamless experience for the beneficiaries. So these integration requirements, which first went into place in 2019. The main integration requirement is that all D-SNPs have to have a state Medicaid contract. So a contract with the state Medicaid agency. That was not always the case. It has been the case though since 2019. And then there is a category of plans, they're called applicable integrated plans, that also have to have a unified appeals process for Medicare and Medicaid. And that's really a smaller number of plans that are even able to do that, but it is a requirement.
Yeah.
And then CMS has created more structures that it's put in place over the last few years, to encourage D-SNPs to integrate more. So they've created definitions for fully integrated dual eligible SNPs, and these are SNPs that have to cover all Medicare and Medicaid services in addition to the Medicare services. There's highly integrated dual eligible SNPs. They're called HIDE SNPs. and a subset of Medicaid services need to be provided by the same entity as the Medicare services, and then they need to coordinate. And then the majority of SNPs are coordination-only D-SNPs, where the members are not receiving Medicaid coverage from the same parent entity, but the plan does have the obligation to coordinate and to do things like do a health risk assessment and, do some planning that takes into consideration the Medicaid coverage as well.
Yeah.
So what we have seen is that CMS is really wanting to push more plans to FIDE status towards full alignment. So they want to see plans enrolling to the extent that they can offer a Medicaid plan in addition to a Medicare plan. They want them to be providing that. And they don't want them to be only enrolling Medicare members and not enrolling Medicaid members. They don't want Medicaid, beneficiaries receiving their Medicaid coverage from a separate entity if they don't have to.
Yeah.
So what they're looking for is for every D-SNP to integrate or to get out.
And that makes sense. I'm trying to think about it from the provider's perspective, and you might not know the
Sure, go ahead.
I probably shouldn't ask this because we didn't talk about it before, but if I'm in the hospital and I'm in a D-SNP and I'm also in an MCO, so I have Medicaid through, say, a different carrier that has a Medicaid managed care plan, and then I have a D-SNP Medicare plan. Is the hospital, say I need something that needs prior authorization, are they having to get it from both? Or would they just go to the SNP? Because I know Medicaid is always the payer of last resort. So I wonder how that plays. That might be a question for another day. Like, I wonder how that plays out.
That is a really good question. Right. That is one of the issues is that there's overlapping benefits.
Yeah. 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 Absolutely. And like who's prior auth controls, and that can't be easy to
Yeah,
deal with.
it does. I do know it requires that coordination requires quite a bit of like personnel at the plan in order
Hmm.
to be able to look at those issues and then also processes to send, claims, grievances, appeals over to the other entity that's providing the Medicaid coverage. So yeah, it makes sense that CMS wants that integration.
Yeah. And I think that's what's driving a lot of this is just the administrative burden on the providers because they don't have employees to do all of this work.
Yes.
They don't, it often ends up being actually the medical practitioner, the physician, the
Mhm.
nurse practitioner that's having to kind of do this off the side of their desk and get these approvals. They are not staffed up to deal with this
Yeah.
on this kind of scale.
Well, and when you think about what is managed care, it makes sense that this is the
Yeah,
role, this is the function of the
it is.
managed care
It
plan.
is. It is. It's just the rest of the system is not equipped to deal with it.
Absolutely. And plans are business teams are very good at figuring out ways to work around some of the complicated rules that CMS has put in place to facilitate that integration. One of those workarounds is called the D-SNP lookalike plan, where a Medicare Advantage organization offers just a regular schmegular MA plan, but over 80% of the members are dual eligibles. And CMS has
Hmm.
said that that's not allowed. If your focus is dual eligibles, if that's what you're targeting with your marketing, it's got to be a true D-SNP plan with the state Medicaid agency contract. And CMS has lowered the threshold over the years for what constitutes a lookalike plan. It started off at 80% and now it's down to 60%. So the rules are tightening. And I think that's really relevant because CMS is now looking at putting those integration requirements in place for C-SNPs or chronic condition SNPs.
Chronic.
Right now,
Yeah.
those lookalike prohibitions, they don't apply to C-SNPs or I-SNPs. but CMS has noticed.
I-SNPs being institutional
Yes,
special needs plans for people in skilled nursing facilities or other institutional settings.
exactly. Yeah. Thank you for defining that. We don't talk about I-SNPs enough. I bet we will, though. I bet we will be. Um,
Hmm.
so CMS is really concerned that dual eligible beneficiaries are now enrolling in these plans rather than D-SNP plans, and frankly, that Medicare Advantage organizations are focusing their efforts on growing the C-SNP enrollment because there isn't that challenging requirement to contract with the state Medicaid agency. There's not the integration requirements. So in its recent proposed rule, CMS actually issued an RFI, a request for information, asking for feedback from the industry on this trend of dual eligible enrollment in C-SNPs. And CMS said that, we think this might be a problem, and we think we might impose some of those requirements, the state Medicaid agency contract requirement in the D-SNP domain. We might look at phasing out look-alike SNPs in the C-SNP area. And then, CMS also said, but we do really recognize that these C-SNPs are important. Chronic conditions, that's been an important agenda item for this CMS since the beginning. And so we do know that they want to support access to treatment and care coordination for people, and they recognize that C-SNPs
Yeah.
are a way to do that.
Yeah. And this kind of reminds me of our kind of going back to the enrollment trends.
Hmm.
If you think about the growth of MA since 2006, when the Medicare Modernization Act of 2005 reforms went into effect that really expanded Medicare Advantage, a lot of people since then have been aging into Medicare and electing Medicare Advantage when they turn 65. So you think about, somebody that turned 65 in 2010, they were probably, relatively speaking, pretty healthy. That population that's grown every year is aging. So that person is now 80. And so I think that's driving some of the things we're hearing about, not just the growth of special needs plans that could be targeted at trying to help some of those older people with more serious health conditions manage those, but the institutional SNPs and just the financial pressure, the pressure on margins as these folks age. And of course, the reimbursement is adjusted, but medical costs can go up very substantially. So the whole system, and then that larger population ending up on the hospital floors, like the whole system as modified by this migration of Medicare beneficiaries into Medicare Advantage, the whole system is having growing pains as it matures, through the decades.
Yeah, there's the maturity element, and then there's also, the wider availability of services and diagnostics. It reminds me
Hmm.
about the conversation about, neurodivergence and mental health. Is
Hmm.
everybody more depressed, or have we gotten better at identifying it? And we know that plans have
Yeah,
gotten
yeah.
very sophisticated at assessing their patients and identifying their conditions, and that's critical to the funding mechanisms, and so
Hmm.
now it's
Yeah,
also incumbent upon the plans to make sure that those conditions get addressed.
yeah, good point. And there's a proposal for a behavioral health star rating
Yes,
measure
the
tied
depression
to
screening.
screening for
Yeah,
depression.
I
Yeah,
think that's a wonderful proposal, and I was surprised. That would be the very first behavioral health measure to be included in
yeah,
the star ratings. So that's definitely a move in the right direction.
yeah. Interesting. So much, Sandy.
I know. So much is changing.
We could keep going.
Yeah, I could talk about D-SNPs forever. We'll probably talk more about them in a future episode. Before we wrap up, did we want to just give our listeners a little preview for some of the other issues we're going to be trying to cover this year?
Sure,
I know that we are, at the very least, we're going to be talking about that OIG compliance update. That is, a huge
definitely.
change. I know that we want to talk about AI. I hope you're not getting tired of talking about AI, but we actually haven't addressed it on this
I
podcast
don't
yet.
think
So I'm
yeah,
excited.
I think we can't escape it. We can't
Yeah,
escape it.
yeah, we can't put our head in the sand. We're going to have a final rule sometime soon, I expect.
Exciting.
Very exciting.
Mhm.
And I know we are going to have more to say on the TPMO landscape because there have been a lot of developments in the industry. Even while CMS has been,
Marketing,
yep,
marketing. Yeah.
exactly. Yeah. I
Yeah.
know CMS has been busy trying to write the rules, but the industry isn't waiting to evolve. So we'll have something to discuss there.
Yeah. Lots going on. Well, thank you. I think this was good. Good recap. It's going to be a busy year, and we'll just keep reading.
Great. Nice to talk to you as always.
Same.
Bye.
Bye. If you enjoyed this episode, please subscribe wherever you get your podcasts. And if you want to find out more, go to strategichealthlaw.com. This podcast is for informational purposes only and should not be considered legal advice. If you need legal advice on any topic we've covered, please consult an attorney with appropriate experience in health law. Our music is Galaxy Love by Johnny Duke. Until next time, thank you for listening to Health Law Simplified.